Okay. So myelodysplastic syndrome, in a very basic general sense, is really when the bone marrow cells are what we call ineffective, in that their job is to make all of the blood cells in the body, the white cells and the red cells and the platelets, and that all comes from an initial bone marrow stem cell. And in MDS, the stem cell is defective, doesn't work well. I tell people it's lazy, so it doesn't do the job of making blood cells like it's supposed to. And it developed this ineffectiveness because of some damage that it acquired over time. So people typically aren't born with myelodysplastic syndrome, but it's something they develop later in life, either related to things like chemotherapy or radiation exposure, or just from living and the requirements kind of day in and day out on those stem cells to do a huge burden of work. So we find myelodysplastic syndrome typically because people complain about fatigue, or they have infections or bleeding, and then we check their blood counts and we see that their blood counts are very abnormal. They may have anemia, or they may have low blood counts in all the lines, low platelet count, low red cell count, and low white cell count. And that helps us then go to the bone marrow and actually test the bone marrow with a bone marrow biopsy sample. And at that time point, when we spread those bone marrow cells out and look at them under the microscope, they look abnormal. So myelodysplastic syndrome, in a very basic sense, means the bone marrow cells look funny because they're damaged and because they're lazy and don't work well. There is a lot that we still don't know about MDS. So I think of MDS as kind of a big wastebasket, because we say anybody that have blood cells that don't work well, they are diagnosed with MDS. But there's lots of different reasons for that happening. As you can imagine, somebody who's 12, very young, and has myelodysplasia, that's probably a different pathophysiology. It came about in a different way compared to somebody who's 80 and has myelodysplasia. We also grade myelodysplasia in different ways. So you can have what we call low-risk disease, in that you may just have mild anemia, you don't need blood transfusions, you don't have significant damage to the bone marrow cells, they're just a little bit lazy, versus people that have what we call high-risk myelodysplastic syndrome, where their risk of developing leukemia is now very high. So they have a much more aggressive, different disease, because that's somebody that may develop leukemia in 3 months or 6 months or a year, versus somebody that has low-risk disease that may go years or even decades before they develop leukemia. So it's a very broad category, and we don't know enough about why people develop MDS. And of course, the why people develop MDS helps us think about how can we prevent it, how can we treat it better, and so there is still a lot of information we need.
Wow. Well, speaking of treatment, what is the current treatment for MDS?
So we have an approach of how do we try to make those cells function better, and how do we reduce their risk of developing leukemia. So kind of a treatment that does not involve a bone marrow transplant. And that can be effective, but it doesn't cure the disease. So it can make the cells function better, it can make them less lazy, but it doesn't get rid of the underlying damage in the stem cell. Versus a bone... I'm sorry? Yeah, so the main class of drugs that we use are a group of drugs called hypomethylating agents, and that includes Vidasa is one of the trade names, so Vidasa and Dacogen. And these are two drugs that are approved for treatment of myelodysplastic syndrome. They try to make the cells function better. So they I tell people they retrain the bone marrow cells so that they do more that they're supposed to. And if there are showing signs of turning into leukemia, it tries to reroute them back to functioning like they're supposed to rather than turning into leukemia cells. And these drugs can be very effective for treating myelodysplastic syndrome, but they don't solve the underlying problem. Other things you can use.
Bone marrow transplant that can solve the underlying problem.
Right. So the bone.
Bone marrow transplant.
I'm sorry?
Is the best way to treat it a bone marrow transplant?
The only way to cure MDS is with the bone marrow transplant. So we can use these drugs and they can be effective, but at some time point they'll stop being effective and the MDS will come back, or the MDS will turn into leukemia, so they don't get rid of the problem. So that's where bone marrow transplant, it's the only way we can get rid of the problem. We take out those damaged cells and put fresh bone marrow cells into the compartment so that now you've got blood-making cells that are no longer lazy, no longer ineffective, and can function better. The other part about a bone marrow transplant that's really important is you get a new immune system with a bone marrow transplant, because we give bone marrow cells, stem cells in that transplant, and we get not only blood-making cells, but we get immune cells. We've found over the years those immune cells can mop up any leftover damaged cells and adds a second layer of benefit to the transplant. So with the bone marrow transplant, the goal is to cure the disease, to get rid of the MDS, and have blood counts that are normal again. That new immune system can be our friend in a bone marrow transplant because it can help mop up disease. That new immune system can also be our barrier to bone marrow transplants, because you put a new immune system into somebody's body, and that new immune system, yeah, it may wipe up the MDS guys and see them as bad. It may see the rest of your body as bad too. And that's what we call graft versus host disease. So to do a bone marrow transplant and to have a donor for bone marrow transplant, we have to match immune systems as best as we can. So what we do first off is we look in brothers and sisters, because you get these immune system markers from mom and dad. So we look to brothers and sisters first to see if they're a perfect match. If they're not, that's when we have to go into the unrelated donor registry to try to find a perfect match. And matching immune systems is really important to making the bone marrow transplant work as well as it can.
Can you tell me a little bit more about exactly what happens in a bone marrow transplant? I think a lot of people are picturing, some kind of surgery where a patient is opened up. They're not thinking of an IV.
Right, exactly. So your question's a good one. We start by getting the person who's going to get the transplant, we have to get their body ready to accept those new cells. So we give them chemotherapy. Sometimes we add in a little bit of radiation, and that makes space for the bone marrow cells, the new bone marrow cells, makes space for those new bone marrow cells to come in. And it also allows the body to take those bone marrow cells. Bone marrow cells are amazing because they live in the bone marrow, but we can stimulate them to come out into the circulation. So we can actually collect them from donors through the peripheral blood by using white cell shots. And the same thing holds true that when we infuse them back in, we infuse them into the blood system, they find their way to the bone marrow and set up camp there. So there's no surgery. You don't have to take them out from the bone marrow and put them back in from the bone marrow. We can actually bring them out to the circulation for collection with just a few days of white cell shots. And then when we infuse them in, it's just like a blood transfusion. We infuse them in and they find their way into the bone marrow space and start to establish a new bone marrow compartment. It's pretty amazing, really.
There's no surgery. The patients that are going through this, tell me a little bit about what they go through. This is not easy for a patient.
Right. So to go through a bone marrow transplant, we do most of our bone marrow transplants still in the hospital, although people are looking at trying to do more of this as an outpatient. But most patients come into the hospital and they usually get anywhere between 5 and 7 days of chemotherapy and with good nausea control medicine to prevent side effects from the chemotherapy. And then we typically give a day break for that chemotherapy to wash its way out of the system, and then we infuse in those new bone marrow cells. And we dose the bone marrow cells to try to give enough to establish that new compartment. But it takes a couple of weeks for them to grow enough and to start producing blood cells again. So that period of time, you get the chemotherapy and you get the stem cell transplant, but it's a couple of weeks where the blood counts are still very low because the new cells haven't started to do their job yet. So that's a period of time where people are in the hospital, they can have mouth sores, they can have fevers or signs of infection. So we support them very aggressively through this low period, knowing that it's going to be just a short period of time. And then we start to see the white cell count come up, and then we start to see the platelet come up, and the red cell count eventually comes up. And that's new donor cells coming into the circulation, and they're starting to do their job again. And then
one person I talked to earlier this week described what she thought what some friends go through as going to the edge of death. Is that an appropriate description of what a patient goes through in a bone marrow transplant?
it really can be. So the most common approach we do with a bone marrow transplant is we give high doses of chemotherapy and high doses of radiation to try to wipe out the bad cells. So we give as much as we can to kill off these bad cells, whether they be leukemia cells or lymphoma cells or MDS cells. And then we get the good guys with the bad guys. And so that's why the blood counts hit 0. And if it weren't for those new stem cells, people wouldn't live from the procedure, because you have to have those new stem cells to come in and make the blood counts again and allow the body to recover. So it's true, we talk about in our literature that we give to patients, we say, if you don't get the transplant, if we give you the chemotherapy and radiation but you don't get the stem cells, you won't live through this procedure. So the stem cells are a vital part of making the transplant successful. But you're right, we do give people very high doses of chemotherapy with the goal of killing off the bad cells, the cancer cells.
Talking specifically about Robert yesterday was so emotional on Good Morning America, and she said, I will be back. But there is a chance that she could not survive this, right?
That is correct. So what are the factors that make a bone marrow transplant not be successful? What are the problems people run into? So one is infection during that low period. Again, you're very susceptible to infection early on because you don't have any barrier with your blood cells. And then even as your blood counts start to come in, that new immune system, remember I said there's a good part of the new immune system and a bad part of the new immune system. The good part we want, the bad part we don't want too much of. So we don't want that new immune system attacking the body. So we have to control it at first. I tell people we don't want that new immune system getting thrown into a new body and kind of waking up like a bucket of water getting thrown on them. That's not the way to wake anybody up. And so we have to gradually wake those new immune cells up in the new body. So your infection risk is very high because first off, you don't have any blood counts. And then even as your blood counts get better, we're still suppressing your immune system. So infections that we got as a kid that we don't think anything about because our immune system keeps them in check. If we don't have an immune system early on, those infections can come back. So we can see a reactivation of viruses in particular, as well as other types of infection. So we have a lot of restrictions that we put our transplant patients through in the first couple of months of transplant to make sure that their infection risk is as low as possible. We give them lots of medicines.
What is the survival rate of MDS when somebody gets a bone marrow transplant?
So the overall survival rate, what plays into that overall survival rate is a lot of different factors. How do we do the transplant? Where is your disease going into transplant? Because the MDS can still come back after transplant. When you look at large studies, the overall survival, meaning what's the survival at 2 years and 5 years and 10 years, because people that are alive at 2 years are usually alive at 10 years. So those numbers range anywhere between 40% and 70%. And we're all shooting for that 70% range, and we're trying to be smarter about how we do transplants. We always need better donors to reduce the rejection rate with transplant, because that plays into your outcomes too, as well as ways to better control infection. And then with these drugs like Vidasa and Dacogen, we can take an MDS that was an aggressive MDS, what we call that high-risk MDS. We can calm it down before transplant with these drugs, and that may make the transplant more effective because the MDS is in a quieter phase going into transplant, easier to kill off with the transplant.
Is there anything else you think I should know?
I think that, Robin Roberts is one of these kind of ideal patients. She's young, she's healthy, she's robust, and I think she's going to do very well with this transplant process. She has a very good match in having a sister that's a match. So I think she's a very good patient from a transplanter standpoint. I think she's going to do very well. But we have to remember that transplant is the only way to cure MDS. And most people with MDS are actually older. So Robin's not the typical person with MDS. And we are, at our facility here and other places, we're trying to make transplant available to people with MDS, even if they're older. So we've looked at, we do research here where we're trying to study that population of 65 to 75-year-olds. How can we still offer them transplant, but we do it in a different way? You can't be as aggressive with the chemotherapy and radiation, but it can still be a very effective procedure and something that we want to offer to as many people as possible because it's the only way to cure MDS. So I think the field is ever changing. We're always trying to make it better, and we're always trying to improve our outcomes and improve the availability of procedures like bone marrow transplant for everyone that deserves to have one. That's also where making the donor pool as big as possible. We always need more bone marrow transplant donors. And again, it's not a procedure where we have to pull them out of the bone marrow. It's a simpler procedure to get bone marrow cells than a lot of people think it is, because we do 4 days of shots. On the 5th day, we collect those stem cells off through the blood. So you don't need a bone marrow procedure to make that happen. So we're always needing more people in the registry so that we can offer this treatment to more people.
Great. Thank you so much, Dr. Meyers, for your time. I really appreciate it.
Thank you. I appreciate it.
There was one thing that Dr. Meyers had said to me, and I think you and I had talked about it, Danielle, about that this is also becoming more common, sort of the good news, bad news story of more people are surviving cancer. And I don't know if feel like you've already touched on that, Danielle, or if you, I don't want to waste your time.
Great, Dr. Meyers, if you could talk to that quickly.
Elisa and I were saying that we're seeing more people like Robin Roberts, what we call secondary MDS, where the MDS is related to the chemotherapy she got for her breast cancer. And, like we talked about, why is that? It's because we're getting better at treating breast cancer. So that's the good news, and people are surviving cancers like breast cancer. The bad news is that the treatment can damage those bone marrow stem cells and make them ineffective and make them at risk of turning into leukemia. So, and also we were saying that people are living longer and healthier longer, and that's where offering transplants to older patients is so important. So we're, again, when you're faced with somebody that's already been through chemotherapy for breast cancer, and then they're getting a bone marrow transplant or facing a bone marrow transplant, we want to try to mold the transplant so that it's tolerated as well as possible. So again, something that we're looking at here continuously, and we're very interested in this population of secondary MDS patients and how we can make the transplant work as well as possible for them and reduce the complications and the toxicity from the transplant because they've already had chemo before.
Dr. Meyers, I also noticed that you were from Northern California. Part of our viewing area is in Northern California, so I wanted to ask you where it was that you grew up.
I actually grew up in Fort Bragg, California.
Fort Bragg, did you say?
Fort Bragg, It's a small town. I tell people that you have San Francisco and you have Eureka, and Fort Bragg is kind of right in the middle. Most people know Mendocino, which is even a smaller town, but seemed to be more popular than Fort Bragg. But yes, I'm a.
Okay, that's not too far away. I think I've driven through there a little bit.
Yep. I'm a timber wolf. Fort Bragg High School.
All right. Well, thank you so much for your time. I really appreciate it. Thank you, Lisa, for setting everything up.
Oh, sure, and if you need anything else, let me know. We'll get this to you as quickly as possible. And then I also just want to make sure you knew that Dr. Meyers is part of the Knight Cancer Institute at OHSU. Not all of the bios have caught up to that fact, and that's where all of this important research is being done that's helping advance treatments.
OHSU, Knight Cancer Institute.
Yeah.
Perfect. Thank you so much.
Thank you.
Thanks.
Bye.
Bye.